Thank you so much for that kind introduction. And at the outset, a big thank you as well as congratulations to the PCOS and the CSI. Especially, let me make a special mention about Dr. Madhuri, my close friend from medical school days, and also Dr. Duru Shah as well as Dr. Mohanan. So good morning to you all. And my slides are visible now? Yeah. And here I go on a slideshow. Am I good to go? Yeah, so my job has been made easier by the previous speaker, Professor Unni. He has said that cardiovascular risk is increased in women with PCOS. So my job is to, how do you, as a gynecologist, go about assessing the cardiovascular risk? In other words, how do you become lady cardiologists, or for that matter, cardiologists to the ladies, not only ladies with PCOS, but all your patients? That is my job. So having said that, by cardiovascular risk, when I say cardiovascular risk, I would be through this lecture talking about atherosclerotic cardiovascular disease risk assessment. And let's take a typical scenario that's coming into your OBGYN OPD for a follow-up. A 41-year-old female who's a known case of PCOS and is on treatment, has recently got diagnosed to have diabetes mellitus, is obese and has got typical metabolic syndrome. And however, now she complains to you of atypical chest pain and heaviness. So how will you go about, how will you proceed to assess her cardiovascular or ASCVD risk, in other words? So before we do that, why do we have to assess this risk? Primarily, to be able to prescribe to her and be preventive about her, prescribe to her if she is at the low end of the spectrum in terms of her 10-year ASCVD risk, which is, if say it's less than 5%, then you will prescribe her mere healthy lifestyles. At the other end of the spectrum, if she's very high risk, has got more than or equal to 20% risk of getting a cardiovascular event. By a cardiovascular event, we mean either non-fatal stroke or a stroke, fatal or non-fatal, or a coronary artery disease event, a heart attack, so to say, or an ACS phenomenon, established coronary artery disease she develops, again, as also a cardiovascular death. So this is the three hard outcomes that we predict her future. And whether she belongs to the intermediate risk group, and whether it is just, we can have just engage into a discussion and not necessarily prescribe primary preventive therapies. By primary preventive therapies, we mean statins and aspirin. And we could resort to other further workup, so to say. Or for that matter, whether she is a negative risk factor. Okay. By that, I mean, for instance, if you have done a coronary artery calcium scoring and she's got a 0 score, we can confidently tell her that she no longer needs any preventative therapies. And finally, very often, some of them might have first-degree relatives who have been having high ASCVD risk. And how do we go about counseling that patient? So having known the why of it, how do we go about going it? We have to look at what Dr. Uni talked about, the traditional risk factors as were described in the Framingham study way back in the 90s. Hypertension, and somebody was talking about cigarette smoking in your young or 30 to 40 age group PCOS patients is extremely high risk factor. And then diabetes mellitus, dyslipidemia, premature family history of ASCVD. By that, you generally mean that her close siblings or her parents have had ASCVD diagnosed at the age less than 55 in men and at the age less than 65 in women. But women are fast catching up, and with the Indian phenotype, for Indian ancestry people, for South Asian ancestry people, we could take that as occurring 10 years earlier. Then obesity, which our patient is also. Then once we have looked at the traditional risk factors, then we should order a lipid profile for that patient. And this is the crux of the talk, either informally for the young people, informally we say, because these are all, we go about calculating their risk by using what is known as a risk calculator. Now, in keeping with the theme of the WHO for this year, for the World Heart Day, for World Heart Day Federation theme, digital, you connect with your devices to risk factor. These are available on mobile apps, as you will see later. And all this is in order to be able to initiate primary prevention therapies. There are so many risk calculators out there, and it is quite and as you and my introduction, she did talk about our collaboration with the American College of Cardiology, and I for one have this ASCVD risk score from the American College of Cardiology even on my cell phone, and it helps you, and I'll take you through it. But Framingham risk score, again from America, this in the 90s, score CVD risk 4 is from the European Society of Cardiology. JBS3 score is typically from UK. Then there is a special Reynolds risk score which was tested out in healthy female adult population. There is a predict CVD risk score from New Zealand. China too has its own risk score. Unfortunately, we do not have a risk score of Indians, and Indians, as I told you, get coronary artery disease as well as strokes a decade earlier than the Western world. Now, one limitation of ASCVD risk score is that it does not account for the family history of premature CVD. It is there as a risk enhancer, but not within the score. And family history of premature coronary artery cardiovascular disease is akin to smoking, as high as smoking, and it puts the siblings of your patients, if your patient's sibling is having premature CVD, then puts her at a 40% risk increase. And if she's an offspring of a parent with premature CVD, the risk goes up to 60 to 75%. The other criticism about ASCVD, it simply tells you yes and no as far as diabetes is concerned. And of course, people who have long-standing diabetes, the risk is actually more, and it doesn't take into account all that, which some other risk scores do. But I think for practical purposes, taking an ASCVD risk score is good. And like I told you, it is available online to you, as also it is available on a mobile app. You simply, this is the mobile app that I'm talking about. It has been updated in 2018, and it's called now ASCVD Plus. And simply by clicking on this, you get this kind of an entry chart to put in right from the gender. All your patients are obviously going to be females. The age, race, ethnicity is also taken into account. Unfortunately, the ethnicity doesn't necessarily talk about Indians as such. And then the total cholesterol, LDL cholesterol, HDL cholesterol, what Dr. Unni was alluding to, whether the patient is on treatment with statins, systolic blood pressure, hypertension, and so on and so forth. So once you have done that, you would then, now this is the algorithmic approach now that we take. I told you about the algorithmic approach. This is applicable to all patients from 20 to 70 years age group. So check the lipid profile once you have looked at the traditional risk factors. If the LDL is very high, for instance, 190 in the Western world, I would put that as, from practical perspective, more than 160, the bad cholesterol. Straight away, you will prescribe aggressive lifestyle change along with statins. Or if it is not so, then you may look at the risk-based age-based assessment. And that is so for the age group 20 to 39, it has to be informal, because you will have to, it considers these people, why do we call it informal? It considers this age group people as being 40 to 70 years, because all studies are in this age group for formal estimation of the 10-year risk score. And the formal estimation wise, you can divide your patients into these 4 categories based on their 10% event rate. Less than 5%, 5 to 7.4%, 7.5 to 19.9%, and high risk is more than 20%. It is the borderline and the intermediate risk score where we are not on what you call shaky ground, or cannot really prescribe preventative therapies directly. Healthy lifestyles, yes, but for them you might want to look at, which this risk calculator also gives, a 30-year risk score, lifetime CVD risk score, which if it is more than 40%, straight away you prescribe and initiate. Otherwise, in this group, you initiate discussion about what prevention strategy you're going to follow. And this we have talked about already. So for our patient, if you have keyed in, she is 41 years of age. She is other as far as the risk ethnicity is concerned, other risk, neither she is black nor white. She has got an LDL cholesterol of 112, total cholesterol 198, a low HDL cholesterol. She is like Dr. Unni talked about. She has the typical metabolic syndrome with obesity and high waist hip ratios. She is not on a treatment with statin, but her blood pressure is fine. She's not on any treatment. Thankfully, she is not a smoker. And what do we do for her? You straight away get the risk in her as being a low risk. But you look at her lifetime ASCVD risk, she's 39%, approaching 40%. You should definitely initiate discussion with this lady and about whether to give statin or not, which because she is just there at 41 years, and though she is on the lower side of the 40 to 70 age group, you click on the advice and you will come across as to what advice to give her in terms of her LDL cholesterol management. You have to prescribe her as a class 1 level of evidence A recommendation, a moderate intensity statin, and a high intensity statin will be, maybe you may also think about high intensity statin. So it's time for you to become what you call cardiologists, the whatever you want to call them, as not a diabetocardiologist or a PCOS cardiologist is what you should become, is my humble plea. So today after the lecture, please do download some kind of a risk calculator. And for her lifestyle, there you say that somebody was asking about smoking, quit the butt is definitely there. But these three things which we assess, that is HDL is the good cholesterol, so H for hypertension, D for diabetes, and L for lipids. To assess her ASCVD risk, we have to then reclassify if she is in the intermediate risk and resort to coronary artery calcium scoring as required. As far as physical activity and healthy diet lifestyle is concerned, it is there. 30 minutes of brisk walking 5 days a week is good enough to reduce the cardiovascular risk, that is to say. Of course, needless to say, this patient has to get onto a obesity reduction. About diabetes, you are already aware of, thanks to PCOS, about metformin therapy. But after that, as a secondary therapy, these are wonder drugs today, SGLT2 inhibitors, and she could become a candidate, especially if there is established for a diabetes management, even by all guidelines, and definitely so if there is an established CVD occurrence in any one of your PCOS patients. So besides that, like I told you, the greatest limitation, family history of premature ASCVD, was not there in the risk calculator. But to enhance the clinician and patient risk discussion, we have what is called as risk enhancing factors. And there is a list of all these which you should be aware of, like family history of premature ASCVD, which I have alluded to, or primary hypercholesterolemia and levels more than 160 to 160 also, you should initiate discussion for sure. The metabolic syndrome, Dr. Unni has spoken about. Again, chronic kidney disease, especially diabetic kidney disease, and some amount of albuminuria coming up or eGFRs going down. Chronic inflammatory conditions are important. So also in your context, history of a premature menopause. So as also patients with preeclampsia in the past, and their high-risk ethnicities already coming into the ASCVD risk calculator. There is a South Asian ancestry. Then other biomarkers that we hear so much about elevated C-reactive protein in during this COVID pandemic. We'll talk about that, elevated LP(a) and others like ankle brachial index and elevated ApoB levels. Now, C-reactive protein, as Dr. Unni mentioned, is a marker of inflammation. So you have to rule out inflammation before you order it in any patient. And what we order is a high sensitivity C-reactive protein, not the usual one. At the lower end of the spectrum, we try to detect with a high sensitivity C-reactive protein. And it has been a known predictor of cardiovascular disease, as is shown by this study, which Dr. Unni has mentioned about, is commonly elevated in women with PCOS. However, there is no consensus on when to get tested about this. The AHA recommends in the intermediate risk group patients doing a HSCRP, and if your HSCRP is more than 3, then it becomes a risk enhancer, as was also shown for PCOS patient in this particular study, which showed that PCOS people compared to the controls had higher levels of C-reactive proteins. So also dyslipidemia, in a meta-analysis, it was shown that the LDL levels as well as lower HDL levels were seen in PCOS patients. The LDL levels were 26 milligram higher, and the triglycerides were 12 milligram higher. That was there in this Korean study. Then lipoprotein A has been identified as an independent risk factor. However, only person who gains by ordering LP(a) is probably the path lab people. May use it as a risk enhancer, but there are no targeted therapies, and we do not get after LP(a), though there is so much literature on it in our scenario. The coronary artery calcification has been found to be more prevalent, is what we have mentioned. So also the metabolic syndrome, BMI, waist circumference, height, bad cholesterols are all associated with coronary artery calcification, as was shown in this study here. So as far as coronary artery calcium scoring, we recommend it for the intermediate predicted risk people or the borderline, the middle group, where the borderline predicted risk people. We do recommend doing a coronary artery calcium measurement, which is a useful tool, and we can decide about whether this group gets onto statin therapy. For instance, this particular patient, it could be a candidate for doing a coronary artery calcium measurement, but based on her diabetes and her other parameters, even the ASCVD risk classification itself tells us that she is a candidate for statin therapy. Now, importantly, in the middle group, you can decide if the coronary artery calcium score is more than or equal to 100, straight away her risk goes upwards. Or if it is downward, if it is 0, for instance, then she gets into a lower caste, becomes low. She's already low by the calculator, but this is important. How do they do it? How do they classify it? 0, no identifiable disease with a CSC score of 0. 1 to 99 is mild. 100 to 399 is moderate, which all translates into the same kind of risk score that we talked about. And 400, more than 400 is severe. So however, it is not intended as a screening for all your ladies, neither for any other general population or for PCOS patient as of now. And then what is the implication of a CAC risk score of 0, especially in our practice, patients who are reluctant to initiate statin therapy, or if they have, or if we want to reinstitute statin therapy because of statin associated side symptoms, you have stopped it, say. Now, typically doctor patients do that. We do not want to take statins because they are the ones who have a nocebo effect and start complaining of muscle symptoms. So if you want to reinstitute statin therapy, simply order a CSC. And if the CSC is on the higher side, that gives incentive enough for the doctor patient also to get started on it. And there are other scenarios, especially the middle-aged adults in the middle-aged group, where your calculated risk score is in the 5 to 7.5% risk, which increases your risk if they are in the borderline risk. And if they have a CSC score risk enhancer, they straight away go into the high risk. Coronary angiography remains the gold standard, but a word of caution here: just because your calcium score was high, don't some disease here and there, people land up ordering coronary angiogram. There is a separate set of indications for coronary angiography, and if somebody is ordered a coronary angiography, then it defeats the purpose. We cannot get coronary angiography done for all, and that is not the way to go. However, on the basis of coronary angiographic studies, the standard PCOS things about patients having hirsutism, lower levels of HDL or higher concentrations of TG are all associations that have been described. So finally, the take-home message here is that although patients with PCOS are at higher risk of ASCVD compared to the general population, as was pointed out so well by my previous speaker also, there are no specific guidelines or scoring systems, or our existing scoring system do not put PCOS yet as a risk enhancer, if not as a part of the risk calculated traditional risk factor. Having said that, the treating gynecologist, all of you people should be aware and be vigilant about the cardiovascular risk while treating your PCOS patients, and be ready at least to take primary preventive measures. It's all about primary prevention when such patients present to you. Detailed studies for risk stratifications are necessary in this patient population, not only our part of the world, not only all over the world. This is absolutely necessary because it adds to the fact that Indians and Indian ethnicity PCOS are probably at higher risk. And you should be able to, in the panel discussion, tell us whether you really have seen lots of coronary artery disease in your patient population. Thank you for your attention.